بسم الله الرحمن الرحيم. السلام عليكم. مع حضراتكم دكتور مجدي خليل، أستاذ أمراض الصدر والرعاية المركزة طب عين شمس. And the topic of the presentation is respiratory failure in COVID-19 patients. رسالة بالأساس موجهة إلى زملائنا من اختصاص غير الأمراض الصدرية اللي بيباشروا ويتابعوا مرضى COVID-19 خلال الفترة الحالية في مستشفيات العزل الجامعية وغير الجامعية. Infection with COVID-19 or respiratory affection in this viral infection can be categorized into two major groups. The first one is non-pneumonic and the second is pneumonic COVID-19. By pneumonic COVID-19 we mean that the lungs are affected, and usually the evidence of affection is got from the high resolution chest CT. Gas exchange is the principal function of the lungs, and as you know, the venous blood comes from every part of the body to the right side of the heart and from the right ventricle to the pulmonary artery. We call the blood in the pulmonary artery as mixed venous blood. It is partially oxygenated blood. The oxygen tension is around 40 millimeter mercury, the saturation is around 70%, and the carbon dioxide tension is around 45 millimeter mercury. Then the blood passes to the pulmonary vascular bed or pulmonary capillaries surrounding the alveolar spaces, where gas exchange takes place between the gas in the alveolar space and the blood in the pulmonary capillaries. The FiO2, or the fraction of inspired oxygen in the alveolar spaces when the patient is breathing room air at sea level, is around 0.21% يعني, and there is negligible amount of carbon dioxide, about 0.04%. By the end of the process of gas exchange in the alveolo-capillary bed, the blood returns back to the pulmonary circulation through the pulmonary veins, and the pulmonary veins carry an oxygenated blood with an arterial oxygen tension more than 80 millimeter mercury and saturation more than 95%. In the young healthy individuals, the PO2 may reach 100 millimeter mercury and saturation may be around 98-99%. Efficient gas exchange has four prerequisites. Number one, adequate ventilation. Number two, adequate perfusion. Number three, matching between the alveolar ventilation and the perfusion. We call this VQ matching. And number four, intact alveolo-capillary membrane. Adequacy of ventilation is maintained through an intact, well-functioning respiratory system, starting from the respiratory center, the neurons, neuromuscular junctions, the respiratory muscles, patent airways, and finally a healthy lung. A defect in any part or more than one part of this system will result in ventilatory insufficiency, while the perfusion is maintained by adequate pulmonary blood flow, which is dependent on the cardiac output and patency of the vascular bed. Regarding ventilation perfusion matching, you know the lung is formed of adjacent units which are intercommunicating. Each unit has a feeding bronchus for aeration or ventilation, and a feeding pulmonary artery and a draining pulmonary vein. Gravity plays a role in the distribution of ventilation and perfusion to different parts of the body. Because the gravity affects the intrapleural pressure gradient, we have some alveoli more ventilated than the other, and because of its effect on the perfusion, we have some areas of the lung more perfused than the other. So, because of the effect of this gravity, you find that one area may have a different ventilation perfusion ratio at different positions of the body. Different position, mainly sitting, supine, and prone. But under healthy conditions and in the absence of abnormalities in the lung, these differences in the ventilation perfusion are all within the physiological limit, more than 0.8, and they can maintain the job of full saturation of the blood returning back to the left side of the heart. Ventilation is also affected by another factor, which is the diaphragmatic expansion, and the perfusion is affected by another factor, which is the tone in the pulmonary vascular tree. Under normal condition, when for some reason one part of the lung or one area of the lung gets hypoventilated, there will be a reflex constriction of the feeding pulmonary arterial tree, resulting in divergence of the blood flow to other more ventilated areas. We call this phenomena O2 regulation. Now, what will happen when the lungs are invaded with the COVID-19 virus? An inflammatory reaction will result. It may be mild, moderate, or severe. There will be an flooding of the alveoli with an inflammatory exudate, inflammatory mediators, and inflammatory cells, which encroaches upon the space in the alveoli available for ventilation. There will be a decrease in alveolar ventilation in the affected area. The second thing, there will be swelling of the interstitium with edema and inflammatory exudate. The third thing is due to the increasing weight and dimensions of the interstitium will be compression on the adjacent alveolar spaces, which is healthy or partially ventilated, resulting in atelectasis. The fourth criteria, which is found in the autopsies of COVID-19 of the lungs, is endotheliitis, which is inflammation and disruption of the endothelium of the pulmonary vascular bed at the area of affection. And finally, there may be obstruction of the microcirculation with thrombi. What will be the result of these histopathological changes? Number one, ventilation perfusion mismatch, which is the main pathophysiology responsible for respiratory failure in pneumonic COVID. The main type of ventilation perfusion mismatch is what we call low ventilation perfusion. Some areas of the lung, some alveoli are poorly or non-aerated, and the normal response by the autoregulatory system, as I told you, is to divert the blood flow from these areas. However, in viral infection, there will be vasoplegia, meaning that there will be no constriction to these feeding pulmonary arteries, and the blood will continue to flow to these poorly ventilated alveoli. Then it results that there will be no gas exchange or no efficient gas exchange in these parts, and the blood coming to the left side of the heart will merge with the blood coming from other parts of the lung to form what we call venous admixture. The effect of the oxygen saturation is dependent on the share of these affected parts of the lung. The more the affection, the more the extent of the inflammatory process, the more the contribution to venous admixture, and the lower is the oxygen tension and oxygen saturation. Another form is what we call high ventilation perfusion, the reverse. In these parts of the lungs, the alveoli are still patent and aerated, so they are ready for the gas exchange. However, there will be no or minimal blood supply to these areas, which may be due to microthrombi or thrombi in the pulmonary vascular tree or a decrease in the cardiac output. So these areas are ventilated but not sharing in the process of gas exchange. It is an area of wasted ventilation. A third pathology is decrease in the compliance of the lungs. These lungs which are inflamed uh, are heavier in weight, are less distensible, so more respiratory muscle effort is needed to allow air to come in. So this decrease in the compliance together with the wasted ventilation will result in increase in the work of breathing. The fourth affection is affection of the respiratory regulatory mechanisms. In response to the hypoxemia, which affects chemoreceptors, and in response to the stress and the stretch on the mechanoreceptors in the inflamed lungs or in the overworking respiratory muscles, afferent signals will go to the respiratory center, and the usual response is to increase the respiratory rate, tachypnea. In COVID infection, there may be a sort of neurotropism in some but not all patients, which also result in increase in the depth of breathing and increase in the tidal volume. So the result is a high respiratory drive with increase in the respiratory rate plus minus an increase in the depth of breathing. The compensation for these changes in the mismatch in the compliance and in the respiratory drive is through the cardiopulmonary reserve. If it is good, it can sustain these burdens, but in comorbidities, whether in the lungs, say for example by COPD or pulmonary fibrosis or whatever, or in the heart by ischemic heart disease or whatever, the pathophysiological changes occur earlier in the course of the disease. They are more profound and usually more difficult to control. Now let us see how these changes affect the plan of management of pneumonic COVID. In milder forms and in early stages of the disease, the affection of the lung is peripheral, abutting the pleura, scarce, discrete, uh, and they contribute little to the overall process of gas exchange. The patient at this stage may complain of cough or commonly complains of cough. He may express some chest discomfort, but usually he doesn't look dyspneic, and if you check the oxygen saturation, you will find it around the normal. It's important to get and record the admission oxygen tension of any patient admitted with COVID disease, because this will be the baseline in the follow-up of this patient. At this moment, you give the antiviral treatment as available. You may add a prophylactic anticoagulant to control the process of microthrombus or thromboembolic possibilities, and you give symptomatic treatment. And usually these patients don't require oxygen tension at this stage unless they have a comorbidity which makes them vulnerable to hypoxemia even with the mildest and earliest forms of the disease. As the disease progresses, more areas of the lung are affected, more inflammatory exudate, more ventilation perfusion mismatching, more decrease in the compliance, more increase in the work of breathing. The patient may express increasing cough, increasing dyspnea, and on examination, most of these people looked dyspneic. However, there is a sector of patients who are heavily affected on the CT but not look such dyspneic. Oxygen saturation is low in these patients, but however, you should notice that there is no good correlation between the level of hypoxemia as determined by pulse oximeter and oxygen saturation and the extent of involvement in the CT scan. So again, you have to monitor the oxygen saturation every patient, whatever the progression of the finding in the CT scan. Added to the management at this stage is anti-inflammatory drugs to control the inflammatory process, which is the base for the pathophysiology and ventilation perfusion mismatch. You may add an antibiotic to prevent secondary infection and prevent confounding factors which may aggravate the inflammatory reaction. And supplemental oxygen is mandatory and it is tailored to the patient demands. We like the patient to be kept more than 94 preferably, or at least more than 92%, and there will be a separate lecture around the supplemental oxygen. And you may encourage the prone position. By prone position, you will get benefit from the gravity by shifting the edema fluid from the dependent parts, which is the lower part of the lung and dorsal part of the lung, to the anterior part of the lung. You will also limit the movement of the anterior part of the chest wall, which is the usual place of expansion during inhalation, and by doing so, it is supposed that you will allow for a better distribution of ventilation, typically to the dorsal part of the lungs. And by acquisition of this position, you may also allow for better effect of the posterior part of the diaphragm, which abutting the lower part of the lower and dorsal part of the lung. So the effect in total is improvement in the ventilation and the distribution of the inhaled air or inhaled oxygen towards the dorsal parts of the lung. Why we insist to improve the ventilation of the dorsal parts of the lung and to shift the burden to the anterior parts of the lung? Simply because the dorsal part of the lung represent a more surface area for gas exchange compared to the anterior part of the lungs. You know, the anterior parts of the lung in a good proportion is occupied by the heart. So we are allowing a better or more available space for gas exchange. However, this phenomena doesn't work in every patient, because I told you in some patients there are some changes in the vascular distribution and in vascular tone. So you try it, and if you find a response, we call this a responder, and we will add prone positioning to supplemental oxygen to maintain satisfactory oxygenation. If the patient proves to be non-responder to the prone position, so you will continue management with supplemental oxygen alone. If the disease progresses more, you will pass in the definition of hypoxemic respiratory failure or respiratory failure type 1, or you can call it ARDS-like syndrome. Again, if the disease progresses, muscle fatigue will ensue, and as I told you, this may occur at an earlier stage if there is an accompanying chronic cardiac or pulmonary disease, and in this case you will get a mixed respiratory failure, and you will add to the hypoxemia hypercapnia, combination of hypoxemia and hypercapnia. At this stage, ventilatory support is mandatory, and the place of management of these cases should be the intermediate or the intensive care unit. Thank you very much for your attention, and I hope the talk is satisfactory to you. If you're still having a question, you can upload to the comments, and we hope that we can answer it individually soon. غنمكم الله السلامة، وإن شاء الله ربنا يوفقكم في أمتكم وترجعوا سالمين غانمين.